Hello, my name is Kendall Baker and I'm a student at the University of Indianapolis, currently studying my undergraduate degree in exercise science. Our research team is interested in the validity and reliability of using individualized occlusion pressures for non-invasive assessment of mitochondrial function. Near-infrared spectroscopy (NIRS) sensor is a non-invasive assessment that can measure the oxygen content within the microvascular structures of skeletal muscles. Relationships between StO2 recovery time following exercise and mitochondrial function have been reported. Oxygen is used by the mitochondria to rephosphorylate phosphocreatine after exercise. Trained individuals will have a higher mitochondrial density and will be able to recover oxygen faster compared to those that are untrained. High occlusion pressures range between 200 to 300 millimeters of mercury and is used during this non-invasive technique to measure mitochondrial function. Individualized occlusion pressures are found using a Doppler ultrasound on the radial artery and might be more tolerable compared to high occlusion pressures. Our research question is, will high occlusion pressure and individualized occlusion pressure produce the same oxygen recovery time constant? Our hypothesis is that both occlusion pressures will produce the same oxygen recovery time constant. Data collection will begin by assessing an individual's IOP, or the individualized occlusion pressure. This will be done by placing a blood pressure cuff on the upper arm of the participant's dominant hand. A Doppler ultrasound will be used distally on the radial artery. As the blood pressure cuff inflates, the blood will become occluded. When the Doppler ultrasound no longer detects blood flow, this will become the individualized occlusion pressure. Following the assessment of the IOP, a NIRS sensor will be placed on the flexor digitorium superficialis. This is a primary muscle that is used during hand grip contraction. The individual will begin with a 15-second isometric maximal contraction. While the individual goes into passive recovery immediately following the contraction, 4 cuffing procedures will be performed. The first cuffing procedure will inflate for 5 seconds, have the individual rest for 5 seconds, and repeat 6 times. Second cuffing procedure will follow consecutively, and the blood pressure cuff will inflate for 7 seconds, deflate for 7 seconds, and repeat 4 times. The third cuffing procedure will inflate for 10 seconds, deflate for 15 seconds, and repeat 4 times. The fourth and last cuffing procedure will inflate for 10 seconds, rest for 20 seconds, and repeat 4 times. This cuffing procedure will be done 2 different times with randomized occlusion pressure. One will be high occlusion pressure, one will be an individualized occlusion pressure. Following data collection, the analysis will begin with the NIRS recovery time constants that will be found using a mono-exponential curve fitting analysis. Relationship between the NIRS recovery time constants from high occlusion pressure and individualized occlusion pressure times will be assessed using a Pearson correlation. Statistical significance will be set at a p-value less than 0.05. Potential limitations of this study will be that the skin fold assessment for the FDS will not be accounted for, as previous research has shown that the thickness of subcutaneous adipose tissue can affect a NIRS signal. In this study, inherently healthy college-age participants will be assessed. Caution should be used when applying the current findings to other populations. Activity level of all participants will not be accounted for. As stated previously, trained individuals and untrained individuals have different mitochondrial densities. Thank you for your time, and I am open for questions.